Hello, my name is Ruben Mesa, and I'm one of the hematologists at the Mayo Clinic in Scottsdale, Arizona. And today's program will focus on the patient with more problematic polycythemia vera. Now, as we think about the therapy of patients with polycythemia vera, we discussed in a separate module frontline therapy with aspirin, control of hematocrit, and cytoreductive therapy with hydroxyurea as our frontline therapy. Now, which individuals that are on such an approach do we consider as having failed that therapy? Failure, in my eyes, can have a variety of different phenotypes. Is it development of an undesired vascular event? Is it difficult to control symptoms such as progressive splenomegaly, itching, etc.? Is it intolerable therapy-associated toxicity, iron deficiency from phlebotomy, excess myelosuppression, non-hematologic toxicity such as a leg ulcer in hydroxyurea? Or have individuals clearly progressed to myelofibrosis or to acute leukemia? The European Leukemia Net developed criteria for what is meant by resistance or intolerance to hydroxyurea, and I was one of the participants in this panel. At the top are the areas that we consider resistant: ongoing need for phlebotomy, excess thrombocytosis or leukocytosis, lack of splenic reduction, significant symptoms after 3 months that people have been on their maximum tolerated dose for at least 2 grams per day. Intolerance on the bottom, based on cytopenias, leg ulcers, GI toxicity, fevers, mucocutaneous toxicity, or recurrent skin cancers. And this at the lowest dose to achieve either a PR or CR by the European Leukemia Net criteria. From my experience, most patients are either 1, resistant because of lack of improvement in spleen, symptoms, etc., or 2, they are really intolerant of the dose necessary to adequately control their counts. Our group published earlier this year in the Journal of Clinical Oncology that individuals that have failed hydroxyurea by those criteria clearly have a much more difficult symptomatic profile in each of the individual symptoms as well as an aggregate when we look at everything from fatigue to spleen-related symptoms. So this is a more difficult group of patients. It's also been demonstrated by our colleagues in Spain that individuals that have failed hydroxyurea have an inadequate survival and certainly have a much more compromised disease course. So again, we're probably selecting out individuals with more difficult disease. Ruxolitinib is a JAK-inhibitor approved in myelofibrosis and now in polycythemia vera. Its approval in polycythemia vera was based on a study called the RESPONSE study in individuals who were resistant or intolerant of hydroxyurea with P-vera, according to those criteria I just showed you, who still had very active disease requiring phlebotomy or having splenomegaly. They were randomized to ruxolitinib versus best alternative therapy, and they could cross over to ruxolitinib. Overall, ruxolitinib was shown to be superior for control of hematocrit, superior reduction in splenomegaly, superior reduction in P-vera-related symptoms, and a trend for less thrombotic events, perhaps on the basis of reduction of the inflammatory cytokines and other difficult milieu present in these patients, as well as a better control of elevated white count, platelet count, and hematocrit. Other than ruxolitinib, there really are very limited treatment options for uncontrolled P-vera. Busulfan can be utilized, but is quite myelosuppressive and may be leukemogenic. Radioactive phosphorus can be helpful in individuals that are very elderly. However, it clearly is leukemogenic and really should be utilized only in individuals with a limited life expectancy. And anagrelide can help to lower the platelet count in these individuals, but is rarely used as single agent in P-vera and has difficulties with tolerability. As we look at the diagnosis of PV, we assess symptoms and risk score, control of hematocrit and use of aspirin. We use our frontline therapy as discussed with hydroxyurea, and patients with worsening symptom burden, vascular events, progression, hydroxyurea resistance, or intolerance, we use ruxolitinib or consider clinical trials. Take-home points: failure of hydroxyurea as frontline for patients with PV is usually on the basis of resistance or intolerance. 2, patients who fail hydroxyurea have a more adverse prognosis and higher symptom burden. 3, ruxolitinib is approved as second-line therapy in PV patients, and one can expect control of hematocrit, splenomegaly, and symptom control through its use. And with that, I thank you for participation in today's conference.